Vinita ma'am, please start.
Yeah, so very good evening to all respected, especially if she joins our beloved and very hard-working, devoted, visionary FOGSI President Dr. Sunita Tenduvalkar in her absentia. Chairperson ICOG FOGSI, a very dynamic Dr. Parag Beniwale, Secretary General Dr. Suvarna Khadilkar, she is also behind this program, and Dr. Sarita Bhalirao, Secretary ICOG FOGSI, who is working so hard to make every program a grand success. And also, I would like to congratulate for organizing such a wonderful program as Guru Mantra, which is going to benefit not only youngsters but also all OBGYN practitioners. In today's webinar, we have got two very senior, renowned speakers, Dr. Patrick Oberon and Dr. Suchitra Pandit, Madam. And to chair again, we have three stalwarts who are great academicians. So, to begin with today's webinar, I would like to request our chairperson ICOG Foxy, who is not only hardworking but equally having a vision and so many program and webinar is going on under your guidance, Dr. Parag Beniwale, to give his welcome address. So, over to you, Dr. Parag Beniwale.
Thank you, Dr. Vinita. Good evening. I bring greetings from ICOG, and it's indeed a pleasure to be talking to you all. My apologies, I'm right now at the airport, so there's a lot of background noise currently. A special welcome to Dr. Patrick O'Brien and, of course, our own Dr. Suchitra Pandit for this episode of Guru Mantra. Guru Mantra is the brainchild of our ICOG, Dr. Sarita, wherein we invite senior faculty and try and learn about obstetrics and gynecology and their management protocols in general. So I'm really excited and looking forward to today's session. Sarita, I think let's begin.
So, I request, sir, there is a newsletter, and I request you, sir, to release this newsletter, which is very important newsletter of ICOG Foxy.
Yeah, office staff, can you flash the newsletter? It's indeed a pleasure to release the first newsletter of this year. Courtesy Dr. Sarita Bhalerao, who took initiative and compiled it, just to showcase the activities of ICOG that we took over on the 11th of January 2025. We wish to continue all these activities for Sarita. Congratulations to you for your efforts, and we shall be circulating this to all our fellows and members, and of course, all our international fellows and honorary fellows. Sarita, would you like to say something?
Yeah, I just thank you, Dr. Parag, and I welcome you all to this very special ICOG Guru Mantra program. Today we have with us Dr. Patrick O'Brien, who's going to from UK, and he's going to speak to us on a very, very interesting and a very new topic, which I think we all need to be very familiar about this GLP-1 and
You're muted, madam.
yeah, I think, can you hear me now? Yeah,
Yes.
we also have Dr. Suchitra Pandit, who's going to speak to us on prediction of preeclampsia. And I welcome you all for this program today. Yeah, I think, Dr. Vinita, we can now
Yes.
introduce
So,
our chairperson.
yeah, so we are fortunate to have three chairpersons, but Alpesh Gandhi, due to some emergency, he is not able to join. So our next chairperson is a renowned personality, Dr. Meena Saman. She is our very own. She is from Patna only, and she is senior consultant at HOD Department of Obstetric and Gynecology, Kurji Holy Family Hospital. She was president of Patna Obs and Gynae Society 2023 to 2025, governing council member ICOG 2023 to 2025, and she was a very hard-working clinical research committee chairperson. When she was chairperson, she did so much of work from 2019 to 2022. She was VP ISOPAB in 2023. Secretary General ISOPAP. She has written 10 chapters in books and several articles in national international journal. So thank you, Meena, for coming and accepting our invitation and to be the part of this program. So next chairperson is none but very good friend of mine, Dr. Pratap Kumar, and always I say that he is a great academician. Uh, I'm really very much thankful to you, sir, for accepting my invitation. And he is head Department of Reproductive Medicine and Surgery, Kasturba Medical College, Manipal Academy of Higher Education, Manipal, Karnataka, India. And his designation is, as I've already said, he is head of the department. And area of interest is reproductive medicine. So over to you, chairpersons, both of
Dr.
you.
Vinita, I think Dr. Sunita has joined. So we will have her address. Dr. Sunita, are you there?
Yeah, I'm very much there. Thank you so much, Sarita. Thank you. And it's always great to be on the ICOG platform with such a great educator and very well curated programs of ICOG. I suppose this is a second master class, I believe. And Dr. Parag Biniwale and Sarita is a very deadly combination at present in ICOG, where the best of the program and best of the scientific faculty they always come out with. And I'm so thankful to them for having me, reminding me all the time. This Guru Mantra web series is really fantastic web series. We have it. And what is most important is because of ICOG, I think probably I stopped anyone doing the webinars by the chairpersons or the vice presidents because ICOG is our academic wing, and it's very, very important that we concentrate and we allow the maximum attention to go on these webinars, which are more quality and educative for postgraduates and the gynecologists alike who are interested in updating their knowledge in their day-to-day practice. So thank you so much, and I wish you all the best. And I'm sure, Parag and Sarita, that these links are available because we keep on getting many messages and mails from all that is it possible for us to get the recordings, and I think it's such a educational material that it should be there on our website all the time for people to look at. So thank you once again, and I'm thankful to each and every faculty. I see so many dynamic faculties here. So difficult to take each and every name, but I value your time and your interest in giving the academics to its best. Thank you.
Thank you very much, ma'am. And I think by seeing you only, we feel encouraged. And I don't know how you are working. I'll only say that there is 24 into 7, but I think you are working 24 into 7 into 7. So I
Mm.
think such a hard work, such a vision with vision you are working. So really, it's a bit.
Thank you. Thank you. Thank you, everyone.
So
So should we, I think Dr. Vinita, we'll ask our chairpersons to
yeah.
introduce our first speaker.
Yes. So I would like to request Dr. Pratap Kumar to introduce our first
But
speaker, Dr.
but let
Patrick.
me say, Obran, thank you so much for coming on a FOGSI ICOG platform. We really enjoy having you. Anytime you come to India or we meet you in the conferences, it's always great to have you. Thank you.
Thank you. Yeah, thank you. Let me introduce Patrick O'Brien. Everybody knows him very well for his academic achievements. Consultant in obstetrics and gynecology, University College of London Hospitals, specialized in high-risk obstetrics maternal medicine, lead of abnormally invasive placental services, vice president of RCOG December 2022 from 19 to 22, president of Royal Society of Medicine section of OB-GYN, Divisional Clinical Editor, Women's Health, Council Member, Royal College of Obstetrics and Gynecology, Institute of Women's Health, London. Chair, Clinical Research Hubs Network Portfolio Board, Chair, Women's Health Division of HCA UK, patron of the charity Safe Hands for Mothers, and several publications. So, welcome to you, Patrick O'Brien, and it's your turn to give your talk.
Thank you very much indeed, Pratap, Sarita, and all of you for inviting me. I really appreciate being here. From sunny London morning, here it is. So it's lovely to be with you. Now, I'm just going to share my talk. Please let me know if you can see it or not. Hopefully you can. You can see that okay?
Yes, we can see.
Fantastic. Thank you very much. So, as Sarita says, I think this is a really exciting and interesting topic. I know I'm a bit biased because I'm interested in maternal medicine, but I think there's great future for these drugs. Now, you would have all have heard of these drugs. There's a whole range of them available, but you could hardly have not heard of Ozempic and Mounjaro and several of these other ones over the last few years. And they've taken the world by storm. I don't think it's an exaggeration to say that. Why is this subject important for us as obstetricians and gynecologists? Well, the number of prescriptions is rising rapidly worldwide. I'll show you some figures in a second. And it's been driven largely by diabetes control, but also now off-label use for obesity. So, for example, in the US, in 2023, over 9 million prescriptions for this class of drugs. And that's a 300% increase since 2020, so just 3 years, and a 600% increase to patients in the age group that we're particularly interested in, sort of between 12 and 25, and 3/4 of all the prescriptions to young adults between the age of 18 and 25 were to women. So this is clearly a big, important issue for the population that we, as obstetricians and gynecologists, look after. And that's the US, those are the US data. But similar trends in the European Union, Australia, and Canada. It's also particularly important because these injectable forms are there at the moment, but the oral forms are beginning to come on stream, and it's likely that in due course they will take over, and clearly they're going to be much easier to administrate, circulate, etc. There have been supply issues because these drugs were so popular and the demand was so great. But now these issues are being overcome, so the population taking these drugs will be even greater. And excuse me, you don't need me to tell you that obesity in women of childbearing age is increasing the world over, the UK, the United States, India, every place. Importantly, of course, half of all pregnancies across the world are unplanned. So a lot of women become pregnant on drugs that they're taking that they wouldn't have deliberately fallen pregnant on, and that includes this class of drugs. And in that regard, it's worth bearing in mind, or starting by saying, that the FDA in the States advises to discontinue this type of drug at least 2 months prior to conception. And look at the surge in the use of these drugs in the United States. The yellow line is the total of all this class of drugs. The blue line is Ozempic, which most people are familiar with. So you can see that it's rocketed in the United States over the last few years. This is the UK, so a smaller scale, but the trend is exactly the same. And this is the use in India, again, a slightly smaller scale than the UK, but you can see the trend is exactly the same. And this is the predicted growth in the market in terms of US $1 billion over the next sort of 10 years or so. And you can see that this exponential rise is predicted to increase. Okay, so how do these drugs work? So GLP stands for glucagon-like peptide, and it's a receptor agonist. So these drugs interact with the GLP-1 receptor on pancreatic beta cells, and by doing that, they enhance insulin secretion, glucose-dependent insulin secretion. They also inhibit glucagon release. So this is how they're particularly effective in the management of diabetes. But as a kind of other beneficial effects, they increase satiety, so you feel full, and that's by a central act in the hypothalamus pituitary axis, and they slow gastric emptying. And it's for these two reasons that they're primarily very effective for weight loss, as you'll be well aware. So the benefits of these drugs for patients are that they are effective for treating type 2 diabetes. They are effective for weight loss. They reduce HbA1c levels. They promote sustained weight loss, and they also offer cardiovascular protection. So lots of potential benefits for these drugs. Now, as I'm sure you're aware, they're not without their side effects, the most important of which are nausea, vomiting, and diarrhea. And clearly, if you have nausea and vomiting, that's going to help you to lose weight, but that's not the primary method of action, of course. But these are side effects that are pretty commonplace. Rare side effects are pancreatitis, gallbladder disease, and on it, as I mentioned already, delayed gastric emptying. So on a population level, from a sort of a government or a public health point of view, what are the pros and cons? Well, the pros, the big pros, are that they reduce obesity-related conditions. And you and I know just how much of an issue this is in terms of cardiovascular risk, diabetic risk, arthritis, all the other risks that go with obesity can be benefited for the individual and on a population level by the use of these drugs. The disadvantages are that they're quite expensive, certainly at the moment, although obviously these costs may come down in due course. The potential overuse and the as yet unknown long-term effects in the population. Interestingly, in populations where there's a rapidly rising rate of use of these drugs, the use of bariatric surgery is going down. And that's as you might expect, although it's not as obvious as you might expect that these drugs are preferable to bariatric surgery, because if you take these drugs, you probably end up taking them for a lifetime. And apart from the inconvenience and side effects of that, the lifetime costs are likely to be a lot higher than the one-off costs of bariatric surgery. And currently in the States and most countries, insurance companies are refusing to cover these drugs, even though you might think that they'd be very cost effective for them to cover these drugs because of their benefits. Nevertheless, the insurance companies still see bariatric surgery as a better or cheaper option because it's a one-off thing, and then the benefits hopefully last for a lifetime. Okay, what about the effects of these drugs in pregnancy? Well, I'll start by saying not a lot of evidence, but over the last couple of years, the evidence is increasing. So there's evidence here that we need to be aware of, and I think changes our practice. Certainly has changed my practice over the last year or two. This is probably the best. And this is from the British Medical Journal just about a year ago. And it's looking at the use of the inadvertent use of these drugs in early pregnancy. Now, before this study, there would be only a few kind of individual case reports, a few small case series, so really nothing of any value for us as clinicians. This study, on the other hand, is multi-center, observational, prospective cohort study, and it's involving 6 teratology information services across 5 countries: Germany, Israel, Italy, Switzerland, and here in the UK. And by prospective, I mean that the women had to have registered for having taken one of these drugs in early pregnancy before the pregnancy progressed. So they had to register at quite an early stage so that the outcomes were collected and observed prospectively. And this is over a fairly prolonged period from 2009 to 2022. And they divided, because they had such a massive database, they divided these women into 3 groups. So the first group is women exposed to these drugs in early pregnancy, either for diabetes or obesity treatment, and about 168 patients. The second group, as comparison, is women with diabetes who hadn't taken these drugs, but had taken at least one other anti-diabetic drug, mostly metformin, during the first trimester. That's 156 women. And then their other control group or comparison group was 163 women who were overweight or obese without diabetes and not taking any of these drugs. So the maternal characteristics were, they tried to match them as well as they could, but not perfect. So if you look, for example, at the age group over 35 years, you'll see that there's a higher proportion of the group with diabetes who are a bit older. So that has the potential to confound the findings. And if you look at, naturally you would expect the overweight or obese reference group to have a higher BMI, although they tried to match these as much as they could to the other groups, but still you can see that the matching was a bit imperfect. Okay, well, what do they find? Well, if you look along the top here first, in the 3 different groups, 1, 2, 3, the GLP-1 receptor agonist group here, the diabetes group, and the overweight group, and you find that there are 3 major birth defects in this group, 3 in this group, 5 in this group. And if you look at the odds ratios, I mean, the confidence intervals are wide because the numbers are quite small. But basically, no statistically significant difference in the rate of major birth defects, which is pretty reassuring. There are two different odds ratios here. This one is kind of adjusted, and this one is adjusted for maternal age, less than 35 or over 35, number of previous pregnancies, and use of more than one medication. So a bit of an effort to kind of standardize their comparison groups. So no difference in major birth defects. And then if you look just down along this column, the three major birth defects that were found in the 117 women who've been taking these drugs, you can see that there are three completely different things. One was congenital abnormalities of the kidney, one was congenital heart defect, and one was a polymalformation syndrome. So no consistent abnormality, small numbers, but no consistent abnormality. So the conclusion from this study, and this is the best and biggest study available yet of the use of these drugs in early pregnancy, is that number one, there's no increase in major defects. They had a whole bunch of secondary outcomes in this study as well, which included large for gestational age, small for gestational age, preterm birth, cesarean section, and live birth. And there were no differences in any of those pregnancy outcomes as well. So further reassurance there. Interestingly enough, there were 4 times as many terminations in the group of women taking the GLP-1 RA drugs. And I think this is particularly interesting because I've come across this already in my practice over the last few months. And they postulated that there may be a lot more terminations in this group, partly because there may be a greater proportion of unplanned pregnancies, because, you know, pretty much by definition, women taking these drugs were not planning to get pregnant while taking the drugs. And secondly, importantly, concerns that when they conceive on these drugs, that maybe the drug might have potentially harmed the baby. And this is a concern that I've seen here in the UK, not just among the women themselves, but also among obstetricians, just because of the lack of evidence that's out there. But I think this study that I've just shown has given us enough evidence to be a bit more confident about this. And I'll come back to recommendations in a few minutes. It's worth pointing out that there are a few limitations of this study, one of which is that most women, as soon as they realize they're pregnant, they discontinue the drug for obvious reasons. So these statistics, these reassuring statistics in terms of abnormal fetal outcome or birth defects do not represent the potential effects of these drugs throughout the entire first trimester, but more dominated by women taking the drug in the early part of the first trimester. Okay, so that was women who inadvertently got pregnant while taking the drug. So the effect of the drug in early pregnancy. This is a different study from the just January of this year in the American Journal. And this is looking at women who took the drug within the 2 years before they got pregnant, so not taking the drug in early pregnancy. And this is a big network and database in the States called the US Collaborative Network in TriNetX. And they looked at women over the age of 18. And as I say, they looked at those women who took these drugs in the 2 years preceding pregnancy. And then they had a control unexposed group, so women who had a history of pregnancy, but no history of using these drugs. And because it's such a massive database, they were able to match these two groups pretty well for age, race, ethnicity, and comorbid conditions, including diabetes. And their primary outcomes were these important pregnancy outcomes: hypertensive disorders of pregnancy, gestational diabetes, preterm birth, and rates of cesarean section. Why do they look at these outcomes? Well, because these are the outcomes that obesity and diabetes play a large role in. So what did they find? Well, very encouraging, reassuring outcome data. They found a reduction in the risk of gestational diabetes, odds ratio of 0.81, reduction in hypertensive disorders of pregnancy, odds ratio of 0.84, reduction in preterm birth, and that's iatrogenic and spontaneous, odds ratios 0.68, so significant reduction. Well, all of these statistically significant, but a clinically significant reduction in this. And cesarean section delivery reduction, odds ratio 0.89. So a reduction in all of these important pregnancy outcomes. So worth bearing in mind that this pretty much mirrors the benefits of weight loss, regardless of the method by which you've lost weight. These benefits that I've just spoken about there pretty much mirror the benefits of weight loss before pregnancy. Improves fertility and ovulation, reduces GDM and hypertension, reduces your chance of cesarean section and fetal macrosomia. So the conclusion from this study is that the use of GLP-1 receptor agonists may be a powerful tool to improve perinatal outcomes in high-risk populations when taken prior to pregnancy to reduce weight prior to pregnancy. Now, clearly, a lot more research is needed on this. I just want to touch briefly on the anesthetic implications of this, because there have been a few case reports over the last few years of increased aspiration during, pulmonary aspiration during general anesthesia in patients taking these drugs. And it makes sense because we know that these drugs cause delayed gastric emptying. And we know that whatever the cause, increases the risk of aspiration around the time of anesthetic. So this is particularly important for people having general anesthesia when taking these drugs, including during pregnancy. For example, for termination of pregnancy in early pregnancy, or ectopic pregnancy, or perhaps, who knows, in the future, these drugs might be used throughout pregnancy. So we need to be aware of this. And this was a consensus statement. There's hardly any real evidence about this, apart from a few case reports, really, and a lot of evidence that these drugs reduce gastric emptying, but very little evidence on the rate of aspiration around the time of GA in people taking these drugs. So this was a consensus statement from all of these anesthetic and obesity groups in the United States and the UK. And they said, based on their expert opinion, that these drugs should be stopped at least a week before elective surgery. If somebody's taking these drugs and need to have a GA, consider the full stomach precautions like rapid sequence induction, cricoid pressure, etc. And ideally, use regional anesthesia where possible. Okay, so if you put all of this together for us as clinicians, what advice should you give to women planning pregnancy who are taking these drugs? Well, number one, you could say that if they take these drugs before pregnancy and use them to lose weight, that will result in beneficial pregnancy outcomes. However, they should discontinue the drugs at least a month before trying to conceive, and if needs be, if they're taking the drugs for managing their diabetes, then switch to insulin or metformin if needed, and aim for the weight loss goal, to achieve weight loss goals before pregnancy, and stop the drugs before pregnancy. Okay, what about advice to somebody who comes to your clinic and say, I've fallen pregnant while taking one of these drugs? Well, stop the drug immediately, because we just don't have good long-term outcome data on women who take the drugs for more prolonged periods during pregnancy. However, reassuringly, right now, there is no evidence to suggest that termination of pregnancy is necessary. There's no evidence to suggest an increased risk of major birth defects. However, it makes sense to offer more frequent ultrasound monitoring throughout the pregnancy, just in case. So in conclusion, these drugs are effective for pre-pregnancy weight loss, and this translates into benefits for subsequent pregnancy in terms of significant outcomes like gestational diabetes, hypertension, cesarean section, and so on. However, there's not currently enough evidence on safety for their use throughout pregnancy, but reassuringly, no evidence of harm for those women who've inadvertently conceived while taking these drugs. Tailored anesthesia is important if women are still taking these drugs. And this is where it's perhaps most exciting, that these drugs are potentially very beneficial for pregnancy for the future. So it may be in, I don't know, a decade's time that we find out that these drugs are safe to use during pregnancy. And then it may well be that using these drugs throughout pregnancy produce significant benefits in terms of managing diabetes, macrosomia, etc., etc. And it might well be like the story about metformin, where it took quite a few years before we appreciated and accepted that metformin was safe to use during pregnancy and beneficial. thank you very much for inviting me. It's a real privilege to be here.
Thank you very much, Patrick. It was a wonderful talk on glucose-like peptide 1 receptor agonist. I think it's going to change the scene of diabetes and weight loss. And I was glad to hear that bariatric surgery is going to go down in future. And you very well explained about how one need to be careful about pregnancy and it has to be stopped before pregnancy planning. And of course, even anesthesia problems may be there. So I think you did explain beautifully the importance of GLP-1. Thank you so much, and I request the coordinators to continue.
Thank you.
So, Dr. Meena, would you like to say something? Is Meena there?
It was a new topic for me, though we've been hearing about its usage and so many important points Dr. Patrick has highlighted. Thank you very much for those new informations that we've gained through you. Thank you, Dr. Patrick.
So, Dr. Patrick, it was really a very wonderful talk you have given on this topic, GLP-1 RA. But I think more research is needed, as you have already said. And if we take precaution, it's a very good wonder drug for diabetes and also for the weight loss.
Can I ask a question if there's time?
Yes,
Yes,
we have
yes,
the
ma'am.
question answer now.
Yeah. Okay. So, when we're giving this drug, Patrick, from what I understood is you have to stop it before, the patient conceives. But during this time, particularly, are you advising some kind of a contraception? One, and two is, can you give folic acid along with this so that if she stops it, she conceives? And, is there a rebound weight gain in the pregnancy?
Yeah, very good questions, Suchitra. So yes, safe to take folic acid. Yes, the ideal is not to conceive on these drugs. So they should be using effective contraception while they're using these drugs to lose weight, even if that's just in the lead up to pregnancy. Yes, so far in people who are not planning to fall pregnant, when they stop these drugs, it is quite common to see a rebound weight gain, and that's why it's looking like people who take these drugs may well need to continue them long term. That's what I was saying about bariatric surgery is one off. These drugs are probably going to be continued long term. We don't know about whether the weight gain the weight gain rebound is excessive in pregnancy. We don't have the data on that yet, but I guess it makes sense. It's a very clever question that if women who don't get pregnant after stopping these drugs are getting rebound weight gain, then you might well expect to see that in pregnancy. But reassuringly, that study that I spoke about that looked at women taking the drug in the 2 years before pregnancy but stopped before pregnancy, these women had better pregnancy outcomes in terms of cesarean sections, preterm birth, etc., etc. So it suggests that if there is a rebound in weight gain, that is not translating into worse pregnancy outcomes.
Right. Thank you. Thank you, Patrick. And lovely to see you after long.
You too.
Yeah. I have a question. Dr. Patrick, thank you. That was a lovely talk. What about after the pregnancy and during lactation? Do we have any idea about whether we can give this? Can they go back on it or do they need to wait?
So, very good question, Sarita. We have no information whatsoever about this. The teratology services are looking at it, but there's hardly any data because women who've been taking this drug have stopped it in pregnancy, and then they come to breastfeed and they say, "Look, I stopped this in pregnancy; it wasn't safe. I'm about to breastfeed now. Can I take it?" And everybody says, "No, don't take it. We haven't got the evidence." So there's just hardly any evidence now. It'll probably take several years before inadvertent use in pregnancy and case reports start to accumulate, but no evidence yet. So it probably seems safer to say no.
I think we can take a few more questions. So if there's anyone from the audience who would like to ask some questions, maybe you could raise your hand or
Dr.
unmute
Poonam Goyal
yourself.
is there. Dr. Poonam, if you can.
Yeah, I think I saw Dr. Suvarna Khadilkar also. Dr. Suvarna, are you there?
Yes, Dr. Vinita, I'm there. Absolutely
Yes.
wonderful talk. And the pertinent question Dr. Madam just asked about Dr. Sarita and Dr. Suchitra Pandit. I just want to know that whether the subcutaneous ones are more good or the oral ones which we are using. Like Munjaro is more good to use. That does it have less side effects? And another thing which I want to, how much is the incidence of pancreatitis with these drugs?
So at the moment, it looks like the injectable forms are better, but
Better.
data are accumulating on the oral forms, and they look very promising, easier to take, et cetera, easier to store, administer, all of that. So, but there are a lot of the new oral drugs being developed at the moment, which look very promising and promise to be as effective as the injectable forms. But it'll also take a few years to collect the longer term outcome data. So the injectable forms have been shown to be effective for managing diabetes and obesity, but also for reducing cardiovascular risk. And clearly that takes a few years to prove. So the oral forms, when they come on stream, even though the short-term benefits are likely soon to be equivalent to the injectable forms, it'll take a few years to see if the cardiovascular benefits are equal.
And pancreatitis, how much like is the incidence of pancreatitis?
Rare, very rare. I haven't got the figures off the top of my head, I'm sorry, but they're very rare. It's very rare.
Thank you, sir.
Thank you.
I think Dr. Suvarna.
Good evening. Good evening.
Good evening, everyone. Can you hear me?
Yes, madam. We can hear
I'm
you.
sorry there was a network issue.
we
I'm
can.
out somewhere. But I really want to. I just heard the lecture through, and it was a fantastic lecture, Dr. Patrick. It was really lovely to listen to the entire deliberations, and I congratulate Dr. Parag and Dr. Sarita and the whole ICOG team. Excellent session going on Guru Mantra, and I really admire the topic that has been chosen for the discussion. And I think you must have finished the release of newsletter. Maybe I missed that, or maybe it is happening. I don't know, but I wish you all the best for the newsletter for the of the ICOG. And I also look forward to another talk by Dr. Suchitra on prediction of preeclampsia. I think she has done a lot of work on in this field. And I really once again congratulate the whole team and thank you so much for making me part of this program. And please continue. I'll again go out of network. So before that, so I would like to have one copy of newsletter if it is already released. Wonderful work going on. Congratulations, Sarita, Parag. Thank you so much.
Thank you, madam. Thank you for your words. And thank you for joining at least your author. Thank you very much. So, Dr. Patrick, I would like to ask your personal experience regarding this drug. You must be using this drug. So, can you share your experience?
Yeah, and of course, I never prescribe it myself. People will be prescribed it by, well, GPs now, or they're sort of a bariatric surgeon or whatever. So I never prescribed it myself. But my experience over the last year is I've seen several women who conceive and turn up in my clinic having fallen pregnant on this drug, or they're taking the drug and they come for pre-pregnancy advice. So at the moment, that's where most of my experience comes from. And sadly, I've seen, just even the last month, I've seen 2 women who conceived on this drug, went to see another obstetrician, were advised, oh, it's probably dangerous, have a termination, and they've had terminations of pregnancy. So I think right now, in our current practice and my current practice, the 2 big areas are the ones that I covered, which is pre-pregnancy counseling and women inadvertently falling pregnant on this drug. I don't see myself ever prescribing this drug, but you never know. Maybe in the future, when women who are overweight come and they come for pre-pregnancy counseling, and I say you should lose weight over the next year before falling pregnant, maybe I'll start to prescribe it, but that's not in our current practice.
Thank you very much. So, any other question from audience side?
I think if we don't have any more questions, then we can move
Yes, we
to the
can move
next
ahead.
talk.
So, the next speaker is none but Dr.
I'd
Suchitra.
like to, Dr. Vinita, I'll just thank Dr. Patrick. Thank you so much, Patrick, for joining us. And on behalf of FOGSI and ICOG, we really enjoyed the talk and Really, we look forward to your participation in other programs as well. Thank you so much.
Thank you very much, Sarita. Lovely to see you all.
Thank you. Lovely seeing you.
So next speaker is none other but Dr. Suchita Pandit Madam, who is past President FOGSI. So Dr. Meena, please go ahead and introduce Madam. Dr. Meena?
Yeah, sorry, there's something going on. Good evening. It's my privilege to be a part of this Gurukul and to introduce a very dear and a very knowledgeable Jain Pandit, who we know has a command on gestosis. So she is consultant, Department of OBGY at the Surya Group of Hospitals, Mumbai. She is chairperson AICC RCOG 17 to 20, and she's been the president Gestosis India Association 16 to 21, president FOGSI and ICOG 14 to 15, and president Mumbai. I mean, she's headed so many societies. She's written so many books, done a lot of work for the adolescents, conceptualized the FOGSI Youth Mela for the empowering youth, done more than 300 such melas, continuing activities, GCPR 8 guidelines in 2014, continuing to work on GCPRs. She's been the Secretary FOGSI UNICEF Science Kishori Adolescent Empowerment Project at Dharavi for 8 years. So we can see she has done such a lot of wonderful work. She's also member in APACI committee and winner of Lord of Planet Awards UK 2019, FICO Women's Award 2018, Maharashtra Medical Council Award 2016, and Honorary Fellowship of Nepal Society, MOGS, Dr. Desai Award for Excellence, FOGSI Korean Award, and a lot more. And very importantly, she's always so enthusiastic and passionate about what she's doing. And she's a wonderful person. Welcome, ma'am. Over to you. We're going to learn a lot more from you on preeclampsia prediction. Ma'am, you're muted.
I'm just unmuting myself. Okay, so the topic that I'm going to be speaking on is prediction and prevention of preeclampsia. It was great listening to Patrick because this is something which people are talking a lot about today. And hopefully we'll have more answers for the future, because diabetes is one of our high-risk factors and obesity is one of our high-risk factors for preeclampsia. So we all know that HDP, that is hypertensive disorders of pregnancy, constitute a perplexing and a clinically challenging group of pregnancy complications that are leading cause of maternal and perinatal morbidity and mortality worldwide. And it occurs in around 10% of pregnant women. And HDP basically includes preeclampsia, eclampsia, gestational hypertension, and chronic hypertension. And HDP ranks only number 2 to hemorrhage as a direct cause of maternal death. However, in certain parts of India, particularly Tamil Nadu, it is almost equivalent to the hemorrhage. So, do we know the definition of preeclampsia? We know that it occurs after 20 weeks of gestation or can present as late as 4 to 6 weeks postpartum. But we also know one important thing is that beyond the diagnosis, there is a high unmet medical need for more reliable predictive markers for preeclampsia, because eventually, if you want to have a good diagnostic test, it should be important, easily available. It should stand the tests of WHO screening criteria, and you must have an adequate interventional method so that you can improve the outcome as well as reduce the unnecessary hospitalization. So let's see, we've already talked about the screening. So something which is easily available, cost effective, does not have many false positive, has less of false negatives, at the same time is reproducible. What is there a test like that? So let's see what are the challenges of the different tests that have occurred in all these years. We had the placental perfusion and vascular resistance dysfunction, the fetoplacental unit dysfunction, the renal dysfunction test, the endothelial and oxidant stress dysfunction, but none of them stood that criteria of WHO. So now what we feel is prediction which is based on assessment of clinical risk factors is probably the recommended criteria. Just give me a minute. I just have an urgent call. I'm just doing a webinar. 15 मिनट में भेज दूं आपको 15 मिनट में भेज दूं मैं just एक talk दे रही हूँ 15 मिनट okay just a minute yeah okay नंबर बता देती हूँ 425 Sorry, Meena. Charging. So let's move towards the current tests. Usually it has been, you've tried to have a simple preeclampsia prediction method. This has been difficult task as a pathogenesis of preeclampsia is complex and involves various factors. But there have been various parameters which have been taken into study designs like the previous histories, the history of chronic kidney disease, diabetes, autoimmune disorders, and all these medical characteristics have been built into a particular program. And that's how you are trying to get out newer and newer models. Vinita, I'll just have to take a 5-minute break because this is a call from the embassy. I'll have to give them the OTP. Sorry.
During the AI activity. So please do join. You can go on the website, fill out your form, look at all the requirements and submit your form before September 31st for the ICOG membership also and for the ICOG fellowship also. Dr. Sujitra, are you ready? You're muted. Sujitra, you are muted. Please unmute yourself.
Yeah, sorry about that, but it was
No
urgent,
problem.
so I couldn't have missed it. Yeah, so basically now we are looking at the predictors of onset and what all do we have. So maternal history, maternal blood pressure, uterine artery Doppler, the biochemical markers and combinations of all of this. So on the basis of this, we have the gestosis score. And this is a newer, it's not so new anymore. It's almost 7 years old now, but now we have got it validated at 2 centers. One study published in Jogi, second on its way to getting published. This gestosis score was based on detection of 27 high-risk factors. And the concept of this score was initiated and further developed by the gestosis score group, Dr. Gorak Mandrupkar, Dr. Sanjay Gupte, myself, Dr. Girija Wag, and Dr. Alpesh Gandhi. And this is what it looks like. On the left-hand side, the black one is all the mild factors. The one with the blue is the moderate risk factors, and the one in the red is the high risk factors. So let's have a look at the mild risk factors. Age less than 19 or more than 35, giving a score of 1. Obesity, BMI 26 to 30, a primary gravid status, Maternal anemia, 8 grams is the cutoff point, short duration of paternity. Women born small for gestational age as 1. MAP more than 85, 1. History of dyslipidemia, polycystic ovarian syndrome, interpregnancy interval of more than 5 years, again gets a point of 1 each. Excessive weight gain during pregnancy, again a point of 1. And conceived with ART, mind you, not IUI, but it is IVF and ICSI. And as far as the moderate risk factors are concerned, it's maternal hypothyroidism, family history of preeclampsia, gestational diabetes mellitus, obesity, BMI more than 30, multiple pregnancy, and HDP during previous pregnancy. And then when you go down, if the woman already is diabetic, chronic hypertension, any kind of thrombophilia, whether it's inherited or acquired, any autoimmune diseases, mental health issues, chronic kidney diseases, and assisted reproductive techniques. And in this, you're looking at an egg donor pregnancy or a surrogacy, which gets a point of 3. So now at the first antenatal visit itself, a careful history is taken, and then you mark the points. If it is 3 or more, the woman is marked at risk for preeclampsia. And when the score is 3 or above 3, preventive measures in the form of low-dose aspirin, 75 to 150. This has to be started along with calcium, 1 to 1.5 grams in the low calcium intake group as early as possible. And this can be continued right up to induction or delivery. Now, the importance or the beauty of this score is every visit, it can be done. If the patient comes early, you can start the low-dose aspirin early if she's under a high risk. But even if she comes beyond 20 weeks, even if that low-dose aspirin is not going to have a value, at least you can identify that she's a high risk. Maybe you can do some other test like the S-split PLGF ratio. And if that is found to be high, you can transfer her to a higher center. You can do more vigilant monitoring. You can counsel her better. So every visit is an opportunity to reduce the risk, and every visit is an opportunity for prevention. So this gestosis score can be downloaded from the Play Store of an Android app. We are working for the Apple phone too. But once this is downloaded, you can actually take printouts and keep it in your labor wards, your antenatal clinics, and attach it to every patient. This history initially may sound very confusing because there are 27 characteristics. But once you've done one, you know how easy it is to do it. You can teach the ANMs, the midwives, as well as the students and the interns also to take this particular score. So the common question asked after this is, what is the correct dose of aspirin? Currently, we are recommending 75. 100 is not always available. 81 is available in the UK. But in the FMF studies, they have used 150. And I clearly asked Leona Poon this question, why 150? Why not 75? At that time, the answer given was because in that RCT, they had a comparison between placebo and 150. And therefore, they found 150 better. But currently, what we feel is the 75 dose has got a good maternal and fetal safety profile. So it is to be taken at bedtime daily till 2 weeks prior to induction. And this is one of the best options that is available. Now, one more important thing is, there is a very good study going on in Safdarjung, and this is a study between 75 and 150. We will know the results by next year. Another important predictor is the blood pressure. The first thing that you take in the OPD, the woman should be sitting comfortably, bladder, bowel empty, no pan or tobacco chewing 1 hour before, no strong coffee 1 hour before. The cuff size should be appropriate, 1.5 times circumference of the arm. So that means very obese women or very thin women, you may have a wrong reading. So be very careful about that. And Korotkov 1 for systolic blood pressure and Korotkov 5 for diastolic blood pressure. If the diastolic blood pressure is persistently less than 40 millimeters of mercury, use muffling sounds or the fourth sounds and make a note of this. So the BP equipment, of course, we understand that the mercury sphygmomanometer is the gold standard, but it's not available at smaller places, at PHCs. So there the calibrated aneroid devices or the automated BP machines can be used. Some of our patients today, even in the private setup, use these automated BP machines and send us the WhatsApp readings. But we tell them that every time they come to see us, or every time when the patient comes to see her gynecologist, carry these machines and recalibrate them. And as I've already mentioned about these points, one important thing is they shouldn't be wearing very tight clothing, because again, that can give you a very wrong reading. They shouldn't have climbed up a flight of stairs and then you make them sit and quickly take the BP. You may get a wrong reading. So be very careful about that. And that's why in bigger OPDs, we always say take at least 3 readings 10 minutes apart. But if the first 2 readings are less than 140 systolic and less than 90 diastolic, you may omit the third reading. But remember, if the BP is 135/85, it is alert. So this means you must counsel the woman frequent BP checkups at home or from the healthcare provider. Call her back the next day or the day after and make sure that you've taken the BP, because early initiation of treatment is very important to prevent the adverse complications. And 140/90 is taken as the standard as suggested by the ISSHP, by the International Dystosis Guidelines, and please counsel the mother about the risks and the need to come for a follow-up. So there is also the full pyres and the mini pyres, which is being used in certain places. And here they feel that the full pyres is a preeclampsia integrated estimation of risk, and this has showed both internal and external validities for adverse maternal outcomes. And let's see what all it contains. So the mini pyres has the parity, gestational age, history of chest pain or dyspnea, headache, visual changes, vaginal bleeding, abdominal pain, and systolic blood pressure. And pulse oximetry is also used. But in the full pyres, along with all this, we're also adding additional labs. That is the platelet count, creatinine, and the SGPT levels. So along with this, you've already taken the history and you already noted the high BP. So you can do this and you can actually predict if you feel they're in the high risk, transfer the patients to a higher center. Now, one of the important things today which is being discussed is the uterine artery Dopplers. And research has shown that increased resistance to blood flow in the uterine arteries in the first trimester is associated with development of preeclampsia. And color flow mapping, mean PI is calculated. And if the PI, that is a pulsatility index, is more than 95th percentile, it is taken as a high risk. And remember, diastolic notch is no longer considered as a criteria. It has been found that the histopathology of placentas of women who've had preeclampsia correlate with the abnormal uterine artery Doppler changes. So that's what the basis of the first trimester scan, which was between 11 to 13 weeks, wherein you looked at the nuchal scan plus the dual marker. If you found that the Pape mom was less than 0.5, it was predictive of a placental dysfunction leading to an FGR. Now, umbilical artery Doppler is the best test for predicting the at-risk fetus in women with early onset hypertension. Combination of the maternal factors and uterine artery PI rates may improve detection rates for preeclampsia from 36 to 59% with a false positive rate of 5%. Now, if the PI is more than 2 standard deviations above the mean and you find that there is a presence of the absent or the reverse end diastolic flow, it means that the screening is positive and low dose aspirin could be started. And obviously, anything that is positive requires a vigilant monitoring. So when you're looking at Dopplers and biochemical markers, yes, it's a good way of prediction. But public hospitals may not always have the trained manpower, the machines, and the biochemical markers, which are expensive. Currently, Government of India has suggested only 2 scans in pregnancy, and the anomaly scan is the mandatory one. And we've been, even when I was president of FOGSI, and the later presidents also have been telling the government, please train the government doctors for the nuchal scan and dual markers. So till that time happens, we have the Dystosis score, easy, handy, and practical to use. Of course, there are other tests which I'm going to be talking about, but let's look at the biochemical markers. The PAPE, everybody knows that this is a large glycosylated protein which is produced by the developing trophoblastic cells. So low levels are associated with a higher incidence of preeclampsia and fetal growth restriction. And first trimester PAPE and second trimester S split by PLGF can actually predict the late onset preeclampsia with detection rate of 88% with a false positive rate of 5%. But remember, Along with the PAPE, they also have the PLGF I just mentioned to you. So what is PLGF? It is the vascular endothelial growth factor, which is involved in the trophoblastic invasion of spiral arteries. And maternal levels between 11 to 13 weeks decrease in pregnancies where there is aneuploidies and impaired placentation. And this particular thing in the second and the third trimesters will predict those who could develop preeclampsia or FGR. But then again, this has a detection rate of 55% for the early and 33% for the late preeclampsia with a false positive rate of 10. So then probably what seems and what researchers have focused on is that when you have a combination of factors, you probably get a better preeclampsia detection rate less than 37 weeks. So if you look at maternal factors and MAP, it is 49.3. But when you combine both these with the uterine artery PI plus PAPE plus the PLGF, you probably get a rate of 81 for preeclampsia detection less than 37 weeks. However, for preeclampsia more than 37 weeks, the rates are almost same, ranging between 38 to 45%. So the ASPRE trial from the Fetal Medical Foundation combines the a priori risk from the maternal factors with the results of combinations of the biophysical and biochemical measurements. And this prospective multicentric study found that screening for preeclampsia at 11 to 13 weeks by combination of the maternal factors and biochemical markers gives an estimated detection rate of screening of 77% for preeclampsia less than 37 weeks and 43% for preeclampsia more than 37 weeks with a false positive rates of 9.2%. And they suggested that administration of aspirin, that is 150 milligrams compared with the placebo, resulted in a 62% reduction in the incidence of preterm preeclampsia, but had no significant effect on the incidence of term preeclampsia. So this is the way it is done, and then it is calculated in the FMF calculator. Wherever the facilities are available, this is being done, but you can sometimes compare the gestosis score and the FMF ASPRE trial study, and you find that there is a lot of comparison there. They're almost similar. Now, let's look at the NICE guidelines. NICE say 10 factors, maternal as well as whatever the medical and obstetric histories are. So they have a very poor performance because they detect preeclampsia only 39% with a false positive rate of 10%. And ICOG says use aspirin in women who've had a history of preeclampsia in more than one pregnancy, or if they've had a delivery for preeclampsia at less than 34 weeks of gestation. But then they, a lot of patients are missed out on only 0.3% of the pregnancies are covered. And ASPRE I've already mentioned to you. So then again, looking at this, the FMF trial is definitely superior to NICE and ICOG. But for India, where access to first trimester screening is not always feasible, the gestosis score seems very, very promising, and it can be done easily and suggests the use of low-dose aspirin right at the first visit. Let's have a look at these angiogenic biomarkers now. SFLT is an anti-angiogenic protein which antagonizes growth factors like VEGF, which are needed to maintain healthy blood vessels in the kidney, liver, or the brain. Now, the levels of SFLT increase prior to the onset of clinical disease and then appear to correlate with disease severity. So the ratio of raised SFLT to the decreased placental growth factor. So this particular ratio, it gets elevated prior to onset of clinical preeclampsia, and this also alerts the clinician. And this was the basis of the prognosis trial, which uses SFLT by PLGF for the short-term prediction. And here it is shown that if the value is less than 38 or 38, it at least predicts that there will be an absence of adverse maternal and perinatal outcomes within 1 week. So it's a valuable aid in diagnosis and can be used in clinical practice. We do have this test available in India. The only problem is it is costly. It is around 5,000 rupees and takes about 3 to 4 days to come. But if more people start using it, probably the cost will come down. And the big advantage is it decreases the healthcare cost and the patient's cost for unnecessary hospital admissions. So this was also the basis of the Parrot trial, where they found that many women were getting unnecessarily admitted because they had a high blood pressure. So Parrot trial tried to find out if you add a single PLGF test, would it help? So here they found that women who had a positive test result, it halved the time to diagnose preeclampsia and significantly lowered the chance of serious complications for women. So on the basis of this, they had the Parrot 2 trial where they combined PLGF along with the SFLIT, and they tried to find out whether that was a better test. But remember, friends, whatever predictions we do, we should not forget about our clinical judgment. Ask the woman, how is she feeling? Sometimes she just says, "Mujhe acha nahi lag raha hai." So what is that? Is it the visual disturbances? Is it the headache? Is it a gastric discomfort? And look at the pedal edema. I just wanted to present to you one particular company has come up with this test, which is the evidence-based comprehensive prenatal screening report with the FT enhanced PE screening. And it actually gives the risk for preeclampsia. And this was again some of the tests where the SFLIT and PLG was adopted. And this is the way it is reported. So if it's less than 38, you're pretty okay. 1 week, you're safe. More than 38 and less than 110, that is closer to 85. This means that the patient will get preeclampsia within the next 4 weeks. But anything above 85, please admit the patient. Anything above 110 is risky. The patient can get a late onset and consider delivery. Let's look at the newer test for prediction. Congo Red is a very promising test developed by the WHO. Here, pregnant women with preeclampsia have misfolded proteins in their urine. And if you add the Congo Red dye, it becomes red in color, probably because there is a filamentous protein aggregate amyloid fibrils. And this is considered as a gold standard. And this was done as a prospective study in Bangladesh and Mexico. And they found that it was correlating fairly well, particularly the Mexico cohort. They found that if the test was positive, 77% of the clinical controls actually developed preeclampsia. Whereas in Bangladesh, they found almost 85% of the cases developed preeclampsia if this GB test was positive. So hopefully we should have more numbers, and then this test is going to be used in clinical practice. Again, dextran sulfate apheresis for removal of the tyrosinase kinase may probably help to improve the outcomes by prolonging the pregnancy for a little more time, because they found that by giving this, the SFLIT levels actually came down. Again, the promising thing is the human mesenchymal stem cells, and they are rich in MSCs which contain the similar features to those found in bone marrow. And they found that if these are given to women, they probably reduce the endotoxin-induced hypertension that occurs in preeclamptic women. So let's look at preventive strategies. Well, there's a very beautiful study which all of you remember as the PROMISE study. So the PROMISE study showed that women who were given who were given progesterone, actually there was a reduced risk of miscarriage, and they had a reduced preterm birth in the selected high group women. So on the basis of this study, the placebo-controlled randomized trials of vaginal progesterone for prevention or treatment of pregnancy complications was analyzed. There were 11 RCTs, of which 3 initiated vaginal progesterone in the first trimester and 8 in the second trimester. And here it was found that when vaginal progesterone 200 milligrams twice a day was started in the first trimester, it lowered the risk of any HDP, and there were nearly 4,431 women. So it reduced the risk of preeclampsia as well as HDP with a moderate certainty evidence. But if it was started in the second trimester, it was not associated with a statistically significant reduction in HDP. So this systematic review found that first trimester initiated vaginal micronized progesterone may actually reduce the risk of HDP and preeclampsia, and probably because it improves the placental position, improves the fetal-placental unit. And this was the study by Romero, Pedromelo et al. And this was published in 24 May last year in the BJOG. Some other preventive measures, statins, there's a lot of work going on. Placenta and vaginal microbiomes, metformin, hydroxychloroquine, L-arginine, probiotics, vitamin Ds, and a lot of work is focused on S-split level regulators, which I just mentioned to you about. So what else is needed? Obviously, we need a lot more training for the healthcare workers. They have to understand the seriousness of HDP. Women who have been in the OPDs with high blood pressure say that they were not satisfied with the information they received and they express unfamiliarity with HDP. They wanted more knowledge. So probably we could have focused information on HDP in the antenatal and the postpartum period and give the information in the required language that the patient can understand. And education of caregivers is very, very important. So friends, this is the last slide. Preconception counseling, very, very essential. Early antenatal registration, use the gestosis score and treat with low-dose aspirin and calcium to prevent preeclampsia. Where possible, do the first trimester scan and reiterate the point if she's going to be a high risk. Use Maxil for preventing eclampsia as well as prevention of recurrent convulsions. And it is also used for the neuroprotection for the fetuses between 26 to 32 weeks. If you feel that the patient is coming in the high risk category, timely transfer to a higher center where you can do a timely delivery and a newborn care is available. Monitoring of the BP in the postpartum period, lifestyle changes, discussing contraception and advising patients to come for a preconception counseling in the future pregnancy is very, very important. Thank you very much. And sorry for that little break which I had to take.
Thank you very much, Dr. Suchitra, for that lovely talk. And no problem for the break. It gave me a little time to update our people about ICOG activities. Dr. Vinita, should we ask our chairpersons?
Yeah, so Dr. Meena and Dr. Pratap Kumar, if there is any questions.
Meena, after you.
Yeah. First, ma'am, that was a wonderful talk. You covered all the clinical aspects. I think it's a clinical problem, and how you've highlighted all the clinical things that come in handy when we are looking at this. And the important point is being every time we have to take note of it, the gestosis score, which is dynamic. And so that also makes us very aware of the things that we don't have to miss out. And every time we have to be aware. And as we become aware, make our patients aware. And like you said, some of the patients complained that they were not really very, knowing about the HTP. So I think that also goes a long way in educating our patients. Then, of course, we have new biomarkers that come, the ultrasound things that the ultrasound that has become very routine. So we are doing it routinely. So both the uterine and all those things. So they all add to it, and our knowledge is over the years improving, and so also our predictive rate and the management strategies, they all have improved, and definitely the outcome has improved over the years. Thank you, ma'am, for the wonderful, clear and beautiful slides you have.
Suchitra, thank you for the lovely lecture. And I know you for so many years. You have the passion of teaching and passion of work everybody appreciates, including all of us. I just have a simple question. I loved your talk on risk prediction, but in my experience, I sometimes feel somebody's BP starts with 90 by 60 at the beginning, and then around 7 months, it becomes 120 by 80. So it was much higher than what she had in the first trimester, though she still doesn't come under the category of preeclampsia. I find if they do the urine albumin in that particular patient, it'll be positive sometimes. So this nobody actually has explained. Do you want to highlight on this point? Is there any relevance on this? Because 90 by 60, 80, sorry, 90 by 60 has become 120 by 80 over 2 months.
Right. So I think, see, what the observation you have made is very, very important. Most of our patients come to us in the, if they come in the second trimester, the BP is already low. So we don't have the correct. If they come earlier, say after the urine pregnancy test is positive, then probably we may be able to get a correct BP. But as you very rightly said earlier, we used to say that if there is a rise of 30 systolic and 15 diastolic from the baseline, that would be significant. That would be an important point to note. In these patients, we don't actually start the low dose aspirin, but as your observation is very correct, keep a watch on them. Now, about proteinuria, I want to mention that sometimes preeclampsia can occur even without proteinuria and can cause a multi-organ damage. So anytime if we feel that there is some kind of a multi-organ damage setting in, yes, this patient can be labeled as a preeclamptic. We don't always have to wait for a proteinuria, because in the earlier classifications, they included proteinuria and FGR. But in the newer ACOG and the ISSHP classifications, they do not use proteinuria or FGR as a criteria for severity, simply because it can occur with something else also. So, but your observation is very right. Keep a watch on these patients. It's like, the white coat hypertension. We tell them, tell them to, ask them to, we just go home. But these, out of nearly 13 to 15% of these patients develop a full-blown preeclampsia. So very rightly keep a watch on these patients also, and keep a watch on the patients that you have said the rise in the systolic blood pressure.
There's one question in the from the audience. Thank you,
Yes.
Suchitra. Ma'am, does a gestosis score useful for predicting late onset of preeclampsia?
Gestosis score is better off for the early onset than the late, because usually if it is an early onset preeclampsia, you want to take the patient forward to 37, 38 weeks maximum and deliver her. If she's severe, probably the score is very high, so you know that this is going to be a severe kind of a patient. So if you've predicted preeclampsia, you've already given the preventive measures, you've already given the vigilant monitoring, and you may be able to take the patient on. But just in case, in the later stages, she comes to you at 24 weeks, then you do the gestosis score, you find that the score is very high, and this is the group of patients where you can apply the S-FLIT by PLGF ratio. If that ratio is coming more than 38, closer to 85 or 100, those are the patients which are likely to develop early or even late preeclampsia. More than 110, then they are more towards the late preeclampsia.
Thank you.
I hope that score is, the S-FLIT PLGF ratio. It's available. Metropolis does it. Lilac does it. A lot of groups do it, but it's expensive.
Yeah,
So we have been after them to reduce the cost so that more and more people can use it.
I agree with you, Suchitra. For the country like vast country like ours, your gestosis score is very good. You can
Yes.
popularize in all the PHCs, and you can actually tick all that, and excellent scoring what you all are developing. Yes.
Thank you.
Can
Thank
I
you,
ask,
Dr.
ma'am?
Suchitra. Yes, Dr. Poonam.
Dr. Suchitra, ma'am, please, you just now in your talk said that we have to do it on every visit. That is what I'm not doing. That is why I just
Okay, no,
explained
no.
that.
Yeah, because see, this is a dynamic score. The
Okay.
advantage of giving low dose aspirin is up to 20 weeks. It helps in some kind of a
Yes.
trophoblastic permeation, and it helps in the placental flow. But after 20 weeks, if you do it, you may not have added aspirin. The patient has come to you late. But at least if the score is coming high, you know that this is a high risk category and this patient may develop preeclampsia. And added to it, as I just told Dr. Pratap Kumar, that if we use the S-FLIT by PLGF ratio along with this, then you can predict the severe outcomes. So every visit is a dynamic visit and is a chance to intervene. So if you find that the score is coming, say 8 in, and she's 24 weeks and she hasn't had low dose aspirin, at least you have to monitor her more
We can
vigilantly for
start from that time also.
BP, for urine, and you're also doing the fetal monitoring as well as the biochemical parameters, whatever is affordable in your setups.
And does the low molecular weight heparin, etc., those things help in these patients, or only we have to stick on
No. Low
ecosprin?
molecular weight heparin has no role in
No role.
prevention of
Okay.
preeclampsia unless it is proven that it is because of APLA positive, inherited thrombophilia positive, or she's had a history of DVT in the previous pregnancy, or she's had a fetal loss in the previous pregnancy due to abruption, say at 24, 25, 26 weeks. She's
Okay.
been investigated, or you don't have the papers, you can re-investigate her. In those patients, only low molecular weight heparin is given. Otherwise, in the standard preeclampsia, low molecular weight heparin has got no role.
No role. Okay. Thank you. Thank you so much.
I have a question for Dr. Suchitra regarding aspirin. I want to know till how late can you start aspirin and till what gestational age should you give it?
Right. very important question. You can start it as early as possible at the first visit if you find the cystosis score is positive. 75 milligrams one daily at night, 9 p.m. can be continued right up to the date of induction or delivery. 75 doesn't have a problem. If now you're following the FMF scoring system, they're talking of 150 and say at the first trimester scan, they are changing and they're saying give 150. If you are giving the 150, the guidelines say that stop it at 36 weeks. Earlier they were saying 34, but now it is 36 weeks. But the truth remains that we don't know whether 150 is the correct dose or 75 is the correct dose. Because with 150, there have been 2 cases of abruption and 1 cases of severe gastritis reported. So let's wait for that trial from Safdarjung. It is done in our own country. And we will know the trial by early next year whether 75 is better. But 75 definitely plays an important role. And I have yet to see a patient having any gastritis because of 75. 75, you can continue right up to the time of induction.
I think also there's a problem of early pregnancy bleeding with the ecospirin. And at least in my practice, I have found that these patients do have spotting, bleeding, and are terrified. So, in that case, would you stop it for some time?
Generally, if they've had an IVF and they've come to, they're already on ecosprin, and they're already on the higher doses. They're on low molecular weight heparin plus 150. In those cases, you can stop that 150 and restart it after 3 to 4 days. But in 75, there is no rule of stopping it at all. You can continue it. And the important thing is people try to take it anytime, but no, it's got to be at night, because that is, research has shown that that is the best time it acts. The optimal action is when you give it at night.
Yeah. Thank you, Dr. Suchitra. Dr. Vinita, do we have any more questions in the chat box, or?
I don't think so. All questions has been answered, I think.
Yeah.
So it was a wonderful talk, ma'am, and really mesmerized me with prediction. We can improve the cases of preeclampsia. We can predict and we can treat the cases of preeclampsia. We can prevent the preeclampsia. That is really very good. So I think we are at the end of this program, and I would like to, for the vote of thanks, I would like to request Dr. Sarita Bhalerao, our dynamic secretary of
Pleasure be
ICOG
there.
FOGSI, for vote of thanks.
Thank you very much, Dr. Vinita. At the outset, I'd like to thank our FOGSI president, Dr. Sunita Tandulwarkar, for all her encouragement. Dr. Parag Biniwale for all the help and support, everything. Dr. Suvarna Khadilkar, our Secretary General FOGSI. A big thank you to Dr. Patrick O'Brien, our speaker from UK, and Dr. Suchitra Pandit for their excellent talks. Suchitra has always been a mentor, a friend, and everything all in one. And it's really, really I'm very grateful to you to agreeing to participate in our ICOG program. It's a pleasure and a privilege to have with us as chairperson Dr. Pratap Kumar. Sir is a renowned academician, and I've had the pleasure of even visiting him in his department at Manipal. Thank you so much, sir, for sparing your time and being on this program. And thank you so much, Dr. Meena Samant, for all your inputs and chairing this program. It's been a pleasure having you as well. Dr. Vinita Singh, you've done a fantastic job. Thank you for all the coordination. It's been a pleasure. Thank you so much. And I'd like to also thank our office staff for organizing everything, our technical staff for conducting this program, and of course, all the delegates who have joined in on this Thursday afternoon to be with us. And do be with us again, and do join us for the next upcoming webinar. Thank you so much.
Thank you, Sarita.
So bye-bye, all of you.
Thank you. And now we come to the end of this program. So bye to everyone. Pranam. Sujita ma'am. Hi. Pranam.
Bye-bye.